I'm Sister Callista Roy, professor and nurse theorist at the Cannell School of Nursing at Boston College. I'm introducing to you the book, Generating Middle Range Theory, Evidence to Practice. And today we will look at part 4 and then the closing part 5. Part 4 deals with the evidence-based practice redefined and exemplified. The focus of this section is to carry out actually the central purpose of the project, to develop and provide evidence-based practice to bridge the gap between knowledge and practice by using research based on one theoretical framework as evidence for best practice. It's based on parts 1, 2, and 3. In 1, we saw the need for bridging the gap and proposal of an innovative way to relate theory to practice by way of research. In part 2, we had seen the 172 studies based on the Roy adaptation model described and critiqued. And then in part 3, the actual generation of the 5 middle range theories from the studies. So then the author of chapter 12 introduces her work by looking at issues about evidence-based practice as well as models about evidence-based practice. Issues relate to the fact that evidence-based practice is significant because it argues that evidence is vital to improving clinical practice. The challenge is to expand our view from a focus on empirics to a focus on diverse patterns of knowing. Consider also whether evidence-based practice is able to be holistic, to provide for primary prevention, and adequately contribute to the development of theory and science. And that models to extend evidence-based practice so far have included, in the author's view, that we take a look at Pearson, Vaughan, and Fitzgerald's work on a systematic review of literature of a particular condition, intervention, or issue. And these authors provide 7 guidelines. A second major model is that approach by Malik and colleagues. In 2010, they used a specific problem-solving method that integrates the best practice and best evidence and patient care data combined with clinical expertise and patient preferences and values. They want people to have inquiring minds and then in step 1, ask questions in a PCOT format. That is, P equals patient population of interest, I is intervention for area of interest, C, comparison intervention group, O, outcome, and T, time. Innovative approaches can still be added to the models, and that's what we propose to do by theory and research-based evidence. So the description of evidence-based practice was first developed by, in the book published in 1999. This was developed from a project of the first research review by the Roy Adaptation Association. Then it was called the Boston-based Adaptation in Nursing Research Society. It had 163 studies that were reviewed, and 118 were used to describe contributions of the Roy adaptation model to nursing science. It was based on the propositions of the Roy adaptation model tested in research studies, and the applications to practice were evaluated on 3 levels, a potential for implementation into practice. The approach for evidence-based practice centered on theory-based research that can provide cumulative knowledge. So we can go over the criteria for levels of evidence-based practice applied to research based on one theory as it was published in a later publication on the Roy model in 2009. And here we have the three levels going across the top, and then the criteria under each one. So level 1 has high implementation, high potential for implementation in practice. And that's because in the research we found that the propositions were supported by more than one study. Secondly, there was unequivocal support for these hypotheses and a low risk, but a very high clinical need. So we declared then that that was high potential, level 1. Level 2 needs further clinical evaluation before implementation. The propositions were supported, but perhaps the generalizability was not clear, or the risk was not clear. But there was still a high clinical need. So we felt that in this case, level 2 were the ones that could be evaluated by advanced practitioners and decided if it was possible that they could move to level 1 and be ready for implementation in practice. Level 3, however, were those that need further testing before implementation. So perhaps the proposition had mixed support in different studies, the generalizability was not clear, or any study that we felt really had a high risk, but still a high clinical need. Then we would ask for that to be submitted for further testing. So this then needs, level 3 needs further testing before implementation. So we have a quite different system for evaluating our evidence for practice. Now, the author appraises, it takes on the summary of how this project appraised and integrated the evidence for practice and for knowledge for practice. The appraisal process involved the fact that all 40 studies with the various qualitative designs had review scores in acceptable ranges. That is, over 80% of the criteria were met. So they were all selected and could be used for evidence-based practice development. The 122 studies with quantitative designs were appraised as meriting further consideration in generating knowledge. 28 had been deleted based on initial criteria, but of the 126 given full review, 4 were below the minimum score. So this project then, to get to evidence-based practice, we had a very thorough appraisal of the research. Now, integration was another issue, how to pull it all together. The 52 Roy Adaptation Model-based Research projects were selected to generate middle-range theory of coping, adapting to life events, loss, chronic conditions, and adapting within families. The study designs for evidence were divided 42% qualitative and 58% quantitative, but all provided us with good evidence and knowledge. The schema for the middle-range theories were organized by common concepts derived from the Roy adaptation model: stimuli, coping processes, and adaptive outcomes. Findings from the studies then were all level 1 evidence-based practice. When reviewed collectively, this evidence then has much stronger significance. The author of the chapter decided to summarize the commonalities among the middle-range theories, and I'll show you one chart here, adapting to developmental changes. And what the author does is show the common stimuli, focal, contextual, residual, expected events related to internal or external changes. All of these are in the developmental category. For example, the child receiving immunizations, the young adult, postpartum problems, managing chores versus childcare, loss of income, middle adulthood, attitudes towards menopause, late adulthood, signing advance directives. Then the author pulls together the interventions, which were all based on either stabilizing or improving cognator-regulator processes. And among all the middle range theories, change in input or stimuli, such as soothing touch, direct action and or selective attention, increase positive attitude and self-esteem, systematically plan ahead, utilize resources to make decisions. The outcomes then of these changes, developmental changes, using these processes were summarized across the 5 middle range theories as including the adaptive mode outcomes of decreasing pain sensation, effective transition to the role of mother, decrease in depression, and a decrease in anxiety. The author goes on to describe this also in situational events, and each one is explained. So this was her first way of integrating the concepts of each of the middle range theory. But another way of integrating the evidence from the middle range theories is to examine the propositions of the middle range theories tested by the studies. So we'll cover just a few examples, and you may recall by the chapters presented, the research studies, that they were organized by clusters of Roy adaptation model propositions. So on this slide, we have all 5 of the clusters, and then the number of middle range propositions that related to each cluster. So for example, cluster 1 of the general propositions of the Roy model all relate to internal coping processes. And at the general level, this might say adaptation takes place over time as the regulator and cognator continue to process stimuli. Then 15 middle range theory propositions relate to that, to all of those of cluster 1. But one middle range level proposition is that time perspective can be useful in resolving moral distress. Cluster 2 is on observable behaviors in one or more adaptive modes. And there, again, we had 15 different middle range theory propositions. So an example at the general level would be adaptation in one mode is affected by adaptation in other modes. An example of a middle range theory proposition there is that relating to others during life challenges is used for support and empathy. Now, cluster 3 relates to internal and external stimuli to the adaptive system, and 19 of the middle range theory propositions were related to stimuli. The 4th cluster is group adaptation, and 5 middle range theory propositions were related to this. The last one is 5, nursing process, and 13 middle range theory propositions related to this. Now, I want to just review what's been going on with this project in general. We've been talking in some ways about levels of theory related to research for practice. At the grand theory level, we can say those were the frameworks used by all of the researchers in their studies. Otherwise, they wouldn't have been included. Then the middle range level of theory was what was derived from the findings of those research studies. So now we are in chapter 12, where we then want to use all that's been done at the grand and middle range levels to actually develop practice level theory. That is the aim of the project, to provide evidence-based practice. So here we're looking at a pathway for knowledge to practice. Knowledge derived from research based on the Roy adaptation model provides nurses with the necessary evidence from research findings to individualize interventions based on assessing the unique pattern of stimuli and coping strategies. However, this evidence needs to be disseminated more widely and efficiently to nurses so that they can use the state-of-the-art, state-of-the-science information in their practice to improve care and quality of life of people. Now, this evidence will be packaged and disseminated for rapid access and direct use, as well as by nurses and by families and individuals. So the ability then to implement the middle range theories and the evidence for practice derived requires a robust technical nursing infrastructure, platform, portal application, and database to support educational dissemination and social support needs of clinicians and patients. We propose then the development of an evidence-based nursing infrastructure and portal that applies best practice recommendations related to the evidence supporting significant Roy adaptation model research-based middle range theories that have been generated to date. So as you look at the figure, I then will give you some background on it, and you'll find more in the textbook. The Nurse Patient Alliance portal infrastructure based on Roy model evidence-based practice would be developed using the same strategies employed by the Cochrane collaboration, so that it's a way that patients and clinicians can browse the database and look for what they need. The database would be developed using the Roy adaptation model middle range theories. It would contain the components of the middle range theories and their associated data and the evidence, that is, interventions, strategies that support adaptation and coping for acute or chronic conditions and/or problems based on the life events, like the new role of becoming a mother or parent, dealing with the role of becoming a caregiver for a sick child or parent, or dealing with the loss of a loved one, bereavement, whether expected or not. On this database then, we would make sections whereby on the main section, the patients or nurses could start with the alliance together, so that there were certain areas that both would be get into. One is dedicated to the nurse, another to the patients, and then the last two are designated as collaborative and consultative areas for the patients and nurses to be able to work together in partnerships. And also included would be the patients' families and friends. So on this home page, the patients and nurses would be instructed to enter or click their designated area in order to search for the focal stimuli, which is condition or problem areas that's confronting them or their patients at a particular time. The individual patient or nurse would be prompted to describe the onset, intensity, severity, and duration of the stimuli, the characteristics of the main concepts of the middle range theory, that is, the contextual and residual components related to the focal. The patients or nurses would be diverted to the main section index of the Nurse Patient Alliance portal to complete an assessment. This assessment could be done in many ways, but would certainly include all of the factors of the uniqueness of the individual, as well as the evidence needed related to the middle range theories of this chapter. When the nurse or patient finishes completing the assessment, an automatic analysis would run via the algorithms embedded in the platform in the application, and the results would generate interventions based on that specific patient's characteristics and goals in order to promote adaptation and coping using the Roy adaptation model. This customized care plan would include the dashboard and metrics, including short and long-term goals. We're down now in the lower section of the figure. And so that an individual nurse or the family, friends, or other health care coaching individuals could track the patient's progress via a timeline toward overall health care objectives of adaptation and coping. The dashboard application would be available to nurses, patients, families, friends, and other providers. And all of this could be made available on devices, the current ones such as cell phones and iPads. And these could also be programmed with alerts and reminders about patient care information that needs to be shared, appointments, medical regimes, anything that's time sensitive. It would make us able to connect to other resources, and subsections and content could also include and generate educational information specific to that patient's developmental situational change. The portal site would have the ability to host on-demand audio, video clips, and so forth. So you see this has a great deal of potential. And our hope would be then we would take everything that we've developed and be able to make it actually available and useful to people. The success in bridging the gap between nursing knowledge and practice, we are going to know when the key to implementing the middle range theories and the evidence-based practice requires that nurses to align effective and meaningful interventions and quality health care with the needs of individuals and families. So with knowledge and evidence behind it, nurses can meet the people where they are at that moment of their lives, understand the context and meaning of the developmental and situational change or challenge for the particular person or family. This approach and the applications proposed can help to simplify interventions and care plans so that individuals feel as though promoting their health is part of their daily routine. Part 5 of the book is on the Roy Adaptation Model-based Research, a global view. We were very aware as we worked on this about knowledge development around the globe. The Roy Adaptation Association has 6 international chapters in Japan, Colombia, Mexico, and Panama, and colleagues in many other countries. We were seeking ways to address the global scope of the Roy Adaptation Model-based research without taking away from the efforts to complete the main project. So there were 2 approaches devised using, first, an expert Roy Adaptation Association consultant for the Latin American countries, and secondly, key informants globally from the files of the theorist. So chapter 13 then uses these approaches and describes the use for 2 specific purposes and aims. 1, research and the Roy Adaptation Model-based research in Latin America, and 2, an estimate of research productivity and theory-based research in selected countries around the globe. The developments in Latin America are noted by the author as, in the last decade in particular in South America, Central America, and in Mexico, there's been a significant change, that is, the adaptation of theoretical nursing models. In many colleges, models are integrated into nursing curricula and in the development of research. They are beginning to have then a large body of dissertations based on nursing conceptual frameworks. In looking at then the Spanish-speaking journals and dissertations from 2000 to 2011, there were 180 studies conducted in Brazil, Chile, Colombia, Cuba, Grenada, Mexico, Panama, and Peru. 56 of these publications using the Roy adaptation model were analyzed. Some summary findings from these by the author include, in the early 2000s, Roy adaptation model-based research was descriptive in nature. Some model concepts were labeled and various elements of the adaptation process were categorized. In the later 2000s, studies used quantitative designs for analysis of the 4 adaptive modes, of their relation to the coping processes, and to describe nursing interventions to promote adaptation. Their research included subjects with chronic illnesses such as arthritis, cancer, and renal diseases, also studies of caregivers of people with disabilities and with terminal illness. Now, the connection in these countries between education and research is very important. They're both developing at the same time. So in this case, the investigator wrote up the directions for further research linking the two. In the context of the connection, as I said, this close connection between growth in education and in research, the following recommendations are made to help to bridge the gap between assumptions and beliefs and real health issues. 1, investigate the value of baccalaureate education in Latin America. 2, investigate synchronization of nursing curricula by evaluating course content of undergraduate and graduate nursing curricula in Latin America. 3, coordinate the linkage between doctoral education and health outcomes. For example, newly initiated doctoral programs can be fertile ground for initiating synchronized doctoral curricula among different nations. Evaluate course outcomes related to graduate clinical faculty expertise and leadership competencies. The implications of the analysis of Roy adaptation model-based research in Latin America then can be summarized as follows. Consolidating progress in understanding of the Roy model and valuing its implementation in research and practice can contribute to positive health outcomes and in this way perhaps positively affect a country's economy. Some financial support allows nurses to seek higher education in master's and doctoral programs, a positive factor for both nursing education and research. And lastly, doctoral programs in Colombia, Panama, and Mexico are developing their research based on the Roy adaptation model and therefore have facilitated student exchange among the countries and promoted multinational research. Now later in the chapter then, we report on theory-based research from the Selective Global Survey. And this actually was an 8-item survey put into an electronic format 40 key informants were judged to be knowledgeable about research publications and nursing theory. These were among the contexts of the nurse theorists. So we admit that the sample was a limitation. Still, some indication of the research and theory is represented. Future work can focus on efforts to get representative samples to validate the findings. The respondents numbered 27 of the original 40, and this was 68% of the sample. But the surveys were completed so that we could report on them from at least 16 countries and territories. You see listed here all the countries, and they varied. We have Palestinian Jerusalem, Switzerland, the Philippines, Sweden, Nigeria, Thailand, Jordan, Japan, Canada, 2 respondents from Turkey, Germany, Spain, Thailand, the Virgin Islands, Ireland, and South Korea. When the respondents were reporting on what positions they held, they talked about they were either nursing education faculty, for the most part, 83%, clinical practice, 11%, research institute professionals, 11%, and other. Those were either adjunct faculty, student, or dean, 17%. Now, interestingly enough, when they reported what positions researchers held, they pretty much used similar percents, but did not use the category other. So they were heavily nursing education faculty and somewhat fewer in research institutes in general, and still a number in clinical practice. Now, I want to orient you to this bar chart. You will see what we were trying to do here was to get an approximate number of nursing research publications each year in their country as reported. So the top bar is greater than 300. The next one is 101 to 300, 26 to 100, and less than 25. Going across the bottom, we have percents at 5% increments. So it starts with 0, goes to 5, 10, out to 35%. So this is people reporting the approximate number of nursing research publications in their country. Greater than 300, we have close to 30%. And also in the category 26 to 100, similarly close to 30%. And then it varies, the 101 to 300 is less than 25%, and the less than 25 would be between 15 and 20%. The places in which this research is published, it starts out at the top with international journals, then journals in other countries, national journals, and local and regional publications. The numbering across the bottom begins at 0 and goes in 5% increments up to 50%. So this again is one respondent reporting approximately where are the published research, where do the research publications appear. International journals is close to over 30%, getting close to 35%. Journals in other countries, less than 20, but greater than 15. National journals is the highest with close to 45%, and local or regional would be about 15%. So both how much public research is done and where it's published varies by country. Now this chart is similar, but the percents go across the top, beginning with 80% and end with 10%. And what is filled in are the number of respondents reporting in each category. So in the first, looking at the row on the left, the category is qualitative research, and you see the split there. One person reports that 80% of the research published in their country would be qualitative, but 5 people report that it would be more likely 10% would be qualitative in their country. Correlational or multivariate, 70%, 1 person reports, 4 people report 40%, 4 people report 30%. Intervention work, you see there that one country 40%, another 20%, and another 10%. Randomized controlled clinical trials, one country reports 70%, one country reports 40%, and 2 report 20%. Moving then to the use of theories in published research. In this, these are bar graphs going upward, and the percents are along the sides. The percents go from 0 at 5% increments up to 35. And the categories across the bottom are based on nursing theories, which goes to a little over 10%, synthesize the variables of the study at a middle range level is over 25%. It depends on the researcher, is over 30%. Not used in nursing research is a little over 15%, and other is a little over 10%. One write-in comment that was interesting, one person wrote, "Unfortunately, currently, too little attention is given to frameworks and nursing models. These should get more attention in nursing research classes again." Now, this table is like one we saw. We have the percents going across the top from 10 to 60, and then different nurse theorists going down the left-hand side. Martha Rogers, 6 people reported that it might be 10% use in research. Of those who use the nurse theorist, 10%. Or in another country, 60%, one person reported. Dorothea Oram, 3 people reported 10%, and then it's spread out all the way across. 2 at 20%, 1 at 30%, 3 at 40%, 2 at 50%, and 1 at 60%. Callista Roy, 1 at 10%, 7 at 20%, 1 at 30%, 3 at 40%, 2 at 50%, and 1 at 60%. Jean Watson, 8 at 10%, 3 at 20%, and 1 at 40%. There were a number of write-ins here, and they included both other theorists from the United States as well as theorists from other countries, both in nursing and not. Now, as we come to the end of this overview of the book and introduction to each of the sections, I want to close by saying there are many levels of acknowledgments I could make about this book. Certainly all of the researchers around the world, and all of the, in particular, all the English-speaking ones that we studied, we are extremely grateful to. And the categories of all these other jobs that went into this project are listed and acknowledged in the front of the book. But I just want to highlight that we had people who did literature searches, research reviewers, we had organizers of the studies, writers to analyze the studies, creators to generate the middle range theories, designers of the evidence-based practice, surveyors of the global research, educators to develop the study guides, and staff at all levels at Springer that turned our ideas into a book. But all of that is given in the front of the book. But I also want to be able to have you, since I have a chance to give a visual, to see the faces. And in particular, the Roy Executive Board, the one who did the initial project published in 1999 is on the left, the upper left. And the book is actually dedicated to Dr. Susan Pollack, last row at the top left. And it was her idea to get together people who were doing research based on the Roy model and see if we could accumulate the knowledge to say more. So she left us much too soon, and the book is dedicated to her. The Roy Adaptation Association Executive Board, as it was when this project started, is to the right there. And if you take time to look at it, you'll note that five of those 8 are also in the first picture. So these people have worked all the way through. The authors who took on the major task of actually writing up each section are in the lower picture. So this has been a very exciting project for us, and we are terribly grateful to everyone who's been involved, and we are very, very happy to leave it in your hands.